We are live now.
Yeah,
So,
we are live on the YouTube. Sanjay.
Yeah. Okay. Good afternoon.
Can you see the logo on the screen? Your screen?
Yeah, I can.
But I can't see it on my screen. Probably there's some problem. Yes, I think we are live now. I'm able to see it on my screen as well.
Shall we start now?
Yes. Please go ahead and let me know when we start the program. Yeah, please start.
Okay.
Roshan,
Okay.
Roshan.
Yes.
I just lost my connection for a second. So how do I access the YouTube questions directly? It will come.
So what you do is you go on YouTube. The link which is given on our invitation.
Yeah, I can see that view streaming.
So you can connect two devices, one laptop and other on mobile. So you can see the questions on mobile, or maybe you can see question on laptop and Zoom discussion. Even I will also open both the windows, and I'll also.
Yeah, I get it.
So yes, please start, Sanjay. And
I have to.
Okay, shall we start now?
Yes, please.
Right. So good afternoon, friends. Once again, we welcome you on today's webinar of Arthroscopy Study Group of India and Arthroscopy Academy webinar. They have become quite popular these days, and every day there is new information coming up on that. Today we have our Japanese friend, Dr. Hiroyuki Sugaya, and he is very popular in India, and we are all fan of his shoulder arthroscopy exploits. So without much ado, I invite Dr. Hiroyuki Sugaya to start his presentation and enthrall us with his skills. Thank you. Floor is yours, Dr. Sugaya.
Yes. Can you hear me?
Yeah, we can hear you.
Okay.
Start the presentation.
That's great. Yeah, I can start my presentation.
Yeah, I'll mute everyone and then you can start. You can share your screen, Hiro.
Okay. Yes. Can you see my screen, right?
Not yet.
Not yet? Really?
No. So what you can do, Hiro, is you can open your presentation in desktop, then go on Zoom icon, press Zoom icon, then open,
I know.
Open only presentation window. Okay, we can see it now. I'll just mute everyone.
You can see that?
Yeah. I'll just mute everyone.
Okay. Okay, can I start my lecture?
Please start.
Okay. Good afternoon, everybody. I'm Hiroyuki Sugaya from Japan. I'm very honored to be a part of the this Arthroscopic Academy's webinar as a faculty. So first, my first talk today is rotator cuff anatomy and its influence on repair technique. This is my disclosure. So supra-infraspinatus footprint. First, the Clark and Harriman described the supra inserts to the superior portion of greater tuberosity, and also infraspinatus inserts to the posterior portion of greater tuberosity. However, when we look at this cadaveric specimen from the top, this is right shoulder, infraspinatus inserts to the greater portion of greater tuberosity. So here's the question. So this is the right shoulder specimen, cadaveric specimen. The tendinous border between the supra and the infra at the most distal insertion areas is unclear. But however, by the hand of anatomist, he removed the surrounding soft tissue clearly, very carefully, and then the border became visible between supra and the infra. So we removed the entire muscles, and this is the remaining tendinous insertion, supra and infraspinatus. And also, interestingly, intramuscular tendon of supraspinatus inserts to the rest of tuberosity beyond the biceps groove. So this is the summary of our study. Supraspinatus inserts to the very anterior portion of the greater tuberosity, and also the part of the rest of tuberosity. On the other hand, the infraspinatus tendon inserts to the greater portion of greater tuberosity. So the surgical implication is if the patient has posterior superior tear like this, U-shaped tear, simple side-to-side repair is not recommended because it is not anatomical. So we always think that posterior stem, to think that we should bring the posterior stem to the front like this. So the U-shaped tear need to be always L-shaped tear like this. Actually, this is the video. So after placing sutures, and we place the side-to-side stitches to the most anterior portion of the supraspinatus, and also the part of the subscap soft tissue, front soft anterior portion of soft tissue. Then we place in another side-to-side stitches, similarly like this. Then the gap is almost closed like this. And after closing the gap, we bring the suture to the lateral and doing bridging repair. So this can avoid having the dog ear creation. So in the paper published in 2008 and 9, that we didn't investigate the capsular insertion. So now that we are trying to investigate the capsular insertion. So the medial side of the rotator cuff, it is very easy to separate the rotator cuff muscle from the capsule like this. So the muscle rotator cuff is flipped over like this. Then we can distinguish the capsular insertion and also the tendinous insertion. After removing entire rotator cuff tendon and muscles, the insertion of the supraspinatus is like this here, and the circles demonstrate the infraspinatus tendon insertion, and the square demonstrate the teres minor tendon insertion. So you can see that the area capsular insertion between the infraspinatus and teres minor is very wide. Actually, we removed the capsule as well, like this. Then the capsular insertion became visible. And actually, the infraspinatus, the capsular insertion between the infraspinatus and teres minor is very wide. So here's the capsular insertion. And this is the infraspinatus. This is a posterior view of the right cadaver shoulder after entire muscle has removed. And infraspinatus tendon, this is teres minor tendon. And in between this area, this area is the thickest capsular insertion between the infraspinatus and teres minor. And also, normally the muscles from the infraspinatus and also teres minor inserts directly to the capsule between the infra and teres minor like this. If you see the skull, you can see like this. This is infraspinatus, this is teres minor. Actually, I use this view for when I perform the arthroscopic ramp research in the shoulder instability. So in the meantime, Steve Burkett proposed the rotator cable concept in 1993. He said this concept is this is a rotator cable, this is a crescent, and the rotator cable, this is an anterior cable, and this one is posterior cable. So this is a very popular concept, especially in the United States. But in the meantime, I found a very interesting paper coming from Germany. This is the humeral semicircular ligament. Actually, I think that this rotator cable is, to me, this is just the capsular thickening from when we look at the rotator cuff from inside. So this is also the capsular thickening. This is humeral semicircular ligament is a very exactly similar thickening of the capsule when we look at from the inside joint. So that this capsular thickening, humeral semicircular ligament has two roots, anterior and posterior, and also the anterior portion has two insertions. One is a superficial insertion, which inserts to the rectus tuberosity. The other one is a deep insertion, which can insert to the most anterior portion of the greater tuberosity. So this deep insertion of the humeral semicircular ligament, this corresponds to the intramuscular tendon insertion of supraspinatus to the greater tuberosity like this. So I think this is a kind of this combined structure should be the anterior cable, so-called anterior cable in the concept of rotator crescent. In the posterior side, this is humeral semicircular ligament incised to the here. This is the exactly same place where the capsular insertion area, the thickest between the infraspinatus and teres minor. So I think this is a posterior cable. So to summarize our concept and rotator cable concept, this is the supraspinatus tendon insertion. This is the infraspinatus tendon and also teres minor tendon insertion. This is anterior cable insertion. This is capsular thickening, humeral semicircular ligament. This is posterior cable insertion. So that's why I can now summarize our supra-infra footprint study, and also combine, if we combine this study to the concept of the with the rotator crescent, rotator cable concept. Intramuscular tendon of the supraspinatus, red one is, and the anterior cable, pink one, have anatomically indistinctive structure. Actually, we cannot distinguish these two structures during surgery. And a posterior cable locates between the infraspinatus and teres minor and supplements the sternus tendon insertion area. So this is a case, very interesting case. This is an anterior cable disruption case, 90-year-old male alpine skier. He fell on the right shoulder during ski racing. 3 months after the injury, he presented me in front of us and complaining pain and severe catching. The range of motion restricted only 100 degrees passive, and active 100 degree passive full, and otherwise normal. And MRI shows the very little bit white spot at the most distal insertion area of the supraspinatus. And this is the arthroscopic view. You see the rotator cuff tear and the subrotator cuff tear just behind the biceps tendon, which is the anterior cable. And also, actually, he has a full thickness tear. So now scope is into the basa. When I open up here, I can see the anterior cable, which is the kind of combination of the intramuscular tendon of supraspinatus and also the anterior deep insertion of the humeral semicircular ligament. So I incorporated this anterior cable to repair, and this is a final repair construct. This is very nice. I think this is very nice. He returned the practice 3 months after surgery, and 6 months, 5 to 6 months, he returned to competition. This is another case, similar case, 27-year-old female cross-country skier. She fell on the left shoulder during practice and complaining motion loss and weakness for 2 months, and she presented in front of us. And range of motion was limited to 95 degrees of elevation, and external rotation was 15 degrees. But this is due to pain, so she doesn't have any stiffness. So the MRI shows a similar findings in a white area inside the tendinous insertion. And this is a actual arthroscopic finding. You see the disruption was found right behind the biceps tendon. This is anterior cable disruption. So she didn't have the full thickness tear, so that I repaired using the pasta repair, intra-articular repair, using the nylon needle like this. And now the notation is performed inside the bursa. Now scope is now switched to the joint. This is the after repair. It looks nice. And she also returned to practice in 3 months after surgery, and also returned to competition 6 months after surgery. Okay, so take-home messages, supra-infra anatomy. Infraspinatus footprint is wider than we expected. Supraspinatus footprint is limited to the anterior greater tuberosity, but works as an anterior cable. And a capsular footprint is thicker than we expected. The widest capsular footprint corresponds to the posterior cable between the infraspinatus and teres minor, and works as tendon. Okay, let's move on to the subscap. The subscap has the largest and the strongest rotator cuff muscle. And what's the comma? The comma is the sign. Comma is the useful landmark of the at the anterior superior lateral corner of the torn subscap tendon. So the group of fibers, the comma is a group of fibers which connects the supraspinatus and subscap based on our anatomical study. So this is the front view of the right shoulder cadaver. And once we remove the biceps tendon like this, we can see that the very thick, robust tendinous insertion area of subscap. This is the most important area of the subscap tendon. So this we investigate the subscap footprint by using the 34 Japanese calligraphy specimen. So based on this study, the most cranial insertion area right next to the biceps tendon, just front to the biceps tendon, is the widest and the very strong footprint memory. Footprint very strong. So if the patient has full thickness subscap tendon tear, I recommend the reconstruction type repair, because we need to increase the initial fixation strength, because this is anatomically and also clinically very, very important structure. So the coracohumeral ligament. So the coracohumeral ligament normally originates from the base of the coracoid and inserts to the both supraspinatus and subscap. Like this picture that we can see, this is from the lateral side. Coracohumeral ligament originates from the base of the coracoid and they both inserts to both supra and subscap. So if you have retracted anterior superior thickness rotator cuff tear, coracohumeral ligament release is very, very important and also very effective. So actually, this is the coracohumeral ligament restricts the mobility of the retractor anterior superior rotator cuff. You see, coracohumeral ligament restricts the motion like this. So once I release the coracohumeral ligament from the base of the coracoid using the scissors or the radio frequency device like this, and mobility improved very much. So this is the most important mobilization procedure like this. Mobility improved very much like this. So I think this is the most important mobilization procedure if you have retracted for thickness anterior superior rotator cuff tears. So tendon mobilization, or if you have reparable retractor tears, coracohumeral ligament release, you need to just release the coracohumeral ligament for the base of the coracoid, and also the capsular release between the rotator cuff and the glenoid. That's also very important. So footprint reconstruction repair has 3 ways: the standard double roll, the suture bridging procedure, and also transosseous. I prefer to perform suture bridging now. I prefer to perform the double roll before, but now suture bridging, I prefer that. So however, the footprint reconstruction repair, the major failure is a so-called type 2 tear is a big issue. It's a muscle tendon junction failure. So normally the people, when we perform, many surgeons prefer to perform the suture bridging technique using the double rolled suture anchors like this and the bracing suture to the tendon and tie the knot first. And after knot tying, bring the suture to the lateral like this. So this may create stress concentration to the medial. That's a kind of strangulation occurs at the knot site. So that may create the muscle tendon junction failure. So our bridging sequences, I prefer to use triple rolled suture anchors. Without tying knot, I just bring the suture to the lateral, and then finally using the remaining suture, by tying the remaining suture, I press down the cuff to the footprint. This can, our bridging is without tying medial roll sutures, so that this can avoid stress concentration to the medial roll. Actually, we're gonna publish in AJSM soon about this procedure and outcome. So the subscap repair, we need to preserve camera and utilize it for repair. So the preserve camera is very important because it's anatomically, subscap and supraspinatus are connected by the intermuscular tendon of supraspinatus. So that I preserve camera and I just pass through the interval, and the rest of the sutures I pass through the tendon like this, and finally I bridge the bridging anchors inside to the bicep groove because I perform the bicep tenotomy or tenodesis in every cases which have subscap there. So this is a view from the dorsal side, and this is the view from the inside joint. So take home messages, the subscap footprint is wide and large, and the most cranial insertion site is the thickest and need to be a secure repair. So that's why I prefer a footprint reconstruction type repair. And the crocodiluminal ligament and the capsular release is critical for the structure tear and the preserve calmer and utilize it for repair. That's my recommendation. Thank you for your attention.
Thank you, Dr. Sugaya.
Yes.
Any questions?
Any questions to Dr. Hiro?
Yeah.
This is
Yes, one by one. JP, yes.
yeah. Dr. Sugaya, according to anatomical footprint, the supraspinatus inserts some part on the tuberosity. So, do you recommend repair on the subscapularis of the supraspinatus?
I don't understand your question well. Can you say it again, please?
Yeah, with the anatomical footprint dissection, okay, supraspinatus, some part is inserted in the lesser tuberosity, the superior part of the lesser tuberosity.
Yes.
So, do you advise repair of the part of the supraspinatus onto the lesser tuberosity?
No. No. My advice is just repairing the torn portion. Supraspinatus tear. If you have a supraspinatus tear, you just reattach the supraspinatus to the greater tuberosity. If you have subscap tear, just reattach the subscap to the lesser tuberosity. So that's an anatomical study. That's a kind of fiber. So if we see an actual patient, we cannot understand the that's fiber relationship. So just we just try repair as we see. So that's why you don't need to care about this. Just a concept, right? So that's why my recommendation is don't make an interval release. If you have retracted anterior superior tear, some surgeon recommends the interval release in order to mobilize that, but I don't recommend this. So don't interval release. Don't perform interval release if you have retracted subscap anterior superior tear, right?
Okay. Sugaya, hi.
Hi.
Hi. You got a 65-year-old patient with 65-year-old with a 2 centimeter tear of the supraspinatus tendon, but the anterior cable is intact. What do you think a non-operative, if you treat him non-operatively, will he do better? Or the result is going to be same? Anterior cable.
I think a small rotator cuff tear, 65 years old patients with small rotator cuff supraspinatus tear with anterior cable intact, normally surgery is not necessary.
Okay.
Because conservative treatment works very well.
When you talk about anterior cable, how much anterior cable you need in that intact in that case? You need a fairly good amount of anterior cable, or
maybe I think from the distance from the biceps, maybe 50 millimeter.
Okay.
Intact. That's okay.
Okay. Thank you.
Yes. In your suture bridge technique, you are tying medial knot only in the one suture. Is it about stress concentration on medial row or strangulation of the cuff while tying all the knots in a standard double row?
Say again, please.
Right.
Sanjay.
So you showed your suture bridge where you use triple loaded anchor.
Right.
And only one pair of sutures you tie knot, that too after doing the lateral row.
Yes.
Not all three you tie. So is it about your theory of concentrating stresses on the medial row or about preventing the strangulation of the cuff by tying the knot?
Both.
In the remaining?
Both.
Okay.
Yeah.
Got it.
Hiro, when we spoke about the anatomy of the supraspinatus tendon on the tuberosity, we always thought about the amount of bone attachment on the tuberosity and the capsular part of it. So is there any relevance of this theory vis-a-vis the blood supply and vascularity of rotator cuff? Because what do you see the results of superior capsular reconstruction in massive cuff tear vis-a-vis the massive cuff repair, partial repair, are completely different. Partial repair doesn't behave same way as we see the behavior of the superior capsular reconstruction. So the vascularity of the supraspinatus onto the tuberosity, does it play a bigger role when you decide the repair pattern?
Yeah, of course, vascularity is very, very important, but we cannot assess the vascularity during surgery. So the, vascularity maybe depends on tendon quality or chronicity and many things. But finally, when we decide to do surgery, all we can do is just repair it anatomically with rest tension based on the anatomy. So
looking at your study, which describes the coracohumeral ligament and the anterior supraspinatus fiber, which creates the bicep pulley over the biceps. So this is the biceps and over which they go.
Yeah.
Do you do the bicep tenodesis in all patients where there is a disruption of anterior cable fibers?
So in my next talk, I will speak about the biceps. So
Okay.
basically, I will cut the biceps everything.
Okay.
Basically, in the chronic rotator cuff tears, I cut every biceps tendon.
Okay. No, but for acute tear and athletic population, like what you have shown 2 cases of anterior cable tear, do you do the tenodesis of biceps or
No.
you leave it as it is?
No,
Because
young patient acute tear, partial thickness, a small tear, I preserve biceps. Because biceps has its role, in their 20s, 30s.
Yeah.
But, situation different. Chronic rotator cuff tears in the late 50s and 60s, 70s, the biceps has already degenerated. So that's going to be the pain generator even after successful rotator cuff repair. So that's why I cut them.
Will it not change the biomechanics of the shoulder joint if you don't do anything to those anterior cable tear without making any efforts to reconstruct the anatomy as it is? Because ultimately it's going to form a part of bicep fully in toto.
Mm-hmm. But I think maybe, young patients are totally different.
Okay.
Young patients different. Young patient with traumatic injuries totally different. We always try to bring it back to the anatomical things, but older patients, chronic patients are different. Like a patient who requires a supercapsular reconstruction is different, who requires partial repair is different. So I think we need to think about this.
Yes. Anyone else on subscap? So, yes.
And what is the indication of biceps tenodesis in young patients?
Okay, so biceps tenodesis, I will speak about that in the next talk.
Second question is regarding the anatomy of subscapularis tendon. When we speak about the facet 1, 2, and 3, 4, the majority of our subscapularis tendon is attached on facet 1 and 2. So is there any role for conservative line of management for a partial tear involving only attachment fibers from the facet 1 or facet 2?
Yeah, I think that's because of a symptom weakness. So the subscap, extensive subscap tear, the normally patient present the weakness. The weakness is the indication of the surgery, but partial thickness tear, sometimes no weakness, just pain. But the pain may be coming from the other aspect, like inflammation or other function problems, so that we can control that first.
Okay.
So I will speak about a little bit about this in the next talk.
Vivek? Yeah.
So, you see, when we repair the subscap, okay, so now if you see there are two classifications which are prevalent. One is LaFosse classification, which is I personally feel easy to apply, intraoperatively, superior third, superior two-third, full thickness and then retracted, vis-a-vis the facet classification. Which one you find easier to apply, and do you, what is the, even if you have understood, because you have got immense experience, have you found a great difference in these two classifications when it comes to the clinical application?
Actually, I don't use a LaFosse classification, but I use a Mike classification. So the tear size, tear, like LaFosse 1, 2, 3 kind of things is, I think that this is very important. The attachment site, how much attachment site disrupted, that's very important, one thing. But the other issue, more important one is a muscle. We need to assess muscles, rotator cuff muscles, subscap muscles. So Guttarier staging, that's very, very important. So we combine these two. Then we assess repairability after mobilization during surgery, then decide how do we perform repair, anatomical repair, or footprint mineralization, other things.
And the subscap tear, which are retracted, and almost sometimes the type 5 one, which are almost close to the glenoid. What is in your practice, do you think they are easier to release and put it back onto the tuberosity? I have found them extremely difficult to repair. I mean, till 4 it's fine, but the minute it is 5, despite all heroics, all releases, somehow it doesn't reach there. Is there anything in the anatomy or anything you would like to say that there is a pre-operative indication that, okay, these repairs you must not go ahead and you say, okay, plan for some kind of a transfer?
The subscap, same stage 2.5, subscap tear or posterior superior tear. Subscap tear is easier to repair. 2.5 stage 3 tear and a posterior superior tear, it's almost impossible to bring the remaining calf to the footprint. But sometimes subscap tear, we can do that. It's because after aggressive mobilization, it's possible. But the LaFosse type 5, 4, 5, very retracted, and also the muscle has that. It's impossible to bring the everything to the anatomical footprint. So in the situation, even after that, I think the patient requires anatomical repair. I do patch.
Okay.
Autograft, grafting for subscap patch. That's very rare. So far, I have done about 7, 8 cases, but sometimes it requires. And also, at least after surgery, after arthroscopic subscap patch, at least we can expect tenodesis effect. We cannot expect the strength recovery, but tenodesis effect we can expect. So that's why the patient very good.
Okay.
Hero, there is a question on YouTube.
Yeah, subscapularis.
Yeah. Ashish, will you ask?
Hero, there is a question from the audience. What is your take on suprascapular nerve release in a massive tear?
I don't.
Never do it.
Never. Actually, I have performed many in the past.
Yes.
More than 10 years ago.
You used to do that.
Nothing has changed. Okay. No change.
But Hero,
yes.
If you see the anatomy wise, when you do your massive and you're now promoting the coracohumeral ligament release, the moment you do CHL release, if you give a tension onto the cuff, there is high chances that you might damage the suprascapular nerve. Don't you think so? When you do a excessive release, it's better to do an suprascapular nerve release, or you still don't believe in it?
I don't. Actually, we did the EMG study before surgery, after suprascapular nerve release, yes or no, and no difference. There's no difference.
Okay. I have another question, Hero. This is related to the predictability value of your rotator cuff management, especially when you see this concept of cable, the anterior cable versus posterior cable, and the clinical radiological evaluation. Is there any predictable value to realize that this cuff is going to behave in this fashion and this rotator cuff is going to behave in other fashion. So can you predict the outcome of the disease with repair, without repair?
I never think about the predictor value.
Because why I'm asking this, because Christian Gerber has presented his paper on critical shoulder angle.
Yes.
And evaluation of those critical shoulder angle in athlete and in older population, he has predicted that certain rotator cuffs will do better and certain rotator cuffs will not do better. But where he doesn't take into consideration the cuff anatomy and the attachment of anterior and posterior cable. Does it correlate that way, the anatomy and critical shoulder value?
I don't know.
Maybe your next paper, next research.
Maybe, critical shoulder angle is very one important, interesting concept, but I don't personally believe everything. So that's a maybe next topic.
next year in lockdown.
Yes.
Yeah. We have any other question?
Yes, from the audience, there is a question.
Yes.
They want to see during the next presentation, coracohumeral ligament release technique. You just show them and focus when you are showing the slide.
Yeah, focus on that technical details.
I'd love to.
I think one point to take from Hero's talk was, as he very rightly said, see, all these cables and capsules, they're lovely as long as the cuff is intact. When you put your scope especially when you do the Bankert surgery, they are very nice on top. But the minute it is torn, the cuff is torn, you can never find out where is capsule, where is cable. It's all one thick rotator cuff. And I think that's the time we have to use his principle to figure out, not every thing which is like a U or a V is a V where it needs a side to side. You got to reduce and see that can it come anteriorly, and then we can repair it more anatomically. So these cable things are all very nice, but as long as, if the cuff is intact and you see the U, it's okay. But once it is torn, you don't know where it is. You got to put it back anatomically and forget it. And I think Pedda, what he was asking now, it's not the cuff. It is actually a part of the cable which is attached onto the small cable, not in all cases, onto the lesser tuberosity. So, and then it is futile to go ahead, put one part of supraspinatus on the, I think, the lesser tuberosity.
Okay. So, Sanjay, can you proceed with the next talk, Sanjay?
Yeah. Yes. So now Hiro is going to show us his tricks about repairing his version of repairable rotator cuff tear repair. Please, Hiro.
Yes. Can you see that?
Yeah, we can see. I'll mute all.
Okay.
Yeah, Hiro, you can go ahead.
Okay. All right, my next talk is cuff repair. Again, this is my disclosure. So rotator cuff tears and pain symptom. This is a very interesting study from the Ken Yamaguchi from St. Louis, 2006 from JBJS. He investigated 588 patients who complained of unilateral shoulder pain and underwent the ultrasound study bilaterally. And interestingly, there are three groups equally divided, no tear groups on both sides, only the tear on the affected side and the tear on both sides. So the age is interestingly, tear on both sides 68 years average, and the tear only on the affected side 59 years old average, and no tear groups even on the affected side. The average age is 49. So that means older patients tends to have asymptomatic rotator cuff tear. So this is another interesting study. This is asymptomatic rotator cuff tear. And my former fellow Atsushi Yamamoto studied he did a medical checkup at a small Japanese mountainous village using ultrasound, and he investigated the rotator cuff tears in 1,366 shoulders in a 683 patient. No, not patient, not individuals. And rotator cuff tear rate was 20.7%. That means 283 rotator cuff tears in 211 individuals. So approximately 2/3 of shoulders with rotator cuff tear did not demonstrate any symptom. So there are many asymptomatic rotator cuff tear, foot thickness rotator cuff tears. So factors affecting rotator cuff symptoms and inflammation, and also the other things, the functional deficit, especially in the scapular dyskinesis, and also the anatomical factor, tear size and pattern and the muscles. So we can control inflammation and anatomical deficit, then even the symptomatic patient becomes asymptomatic, so that our then even after conservative treatment, the refractory symptom remains, the surgery, this is a surgical indication. Based on my experience, maybe 30–40% of rotator cuff tear patient require surgery. Otherwise, conservative treatment works very well. So that's why I want you to know that every single rotator cuff patient does not require surgery. So talking about surgery, the use of arthroscopy. Arthroscopy is a study using shoulder surgery in the 1980s. First, arthroscopic subacromial decompression, arthroscopic assisted mini open repair, and old arthroscopic repair. These guys are very famous Americans. And my personally, my first arthroscopic rotator cuff repair performed around the year of 2000. I started with single row, but eventually changed to double row. The survey, this is an interesting survey during ASES Specialty Day, during the Academy meeting. Question: how do you treat a 50-year-old patient with a medium-sized thickness tears associated with typical impingement sign? In 2002 in Dallas, 20% old arthroscopic repair, 40% medium, 40% open. 2003 in New Orleans, 40% LCR, 40% mini open, 20% open. So after that, number of patients a number of doctors who prefer to perform the old arthroscopic rotator cuff repair increased a lot. In our society, Japan Shoulder Society, we did a similar survey in 2009. In the 2009, then 63% said they performed the old arthroscopic procedure. In the 2014, same survey, 90% do arthroscopic rotator cuff. 10%, only 10% open or mini open. So right now, I think maybe more than 95% perform arthroscopic, prefer perform arthroscopic rotator cuff repair in Japan. I think maybe in the world as well. So the arthroscopic rotator cuff repair is getting very popular. So here comes the question: is arthroscopic rotator cuff repair equivalent to open or mini open repair? So that's why we need to investigate repair integrity. So reported repair rate was 20–90% in open and mini open, and based on these articles. This one, repair integrity, reported repair integrity is influenced by the pre-op, tear size, and tissue quality, and many repairs are functionally doing well, and a better function outcome established in the shoulders with better integrity. So the single row, we started single row repair, arthroscopic rotator cuff repair like this. So the functional outcome is favorable in early single row repair, and also repair integrity after single row repairs. Pascal reported extremely good outcome, 29% repair rate, and he reported JBJ's 2005 using his tension band single row technique. And also at the same time, the similar time, the Risa Garaz and Ken Yamaguchi's group reported 94% repair rate for large and massive tears. So of course, the patient population is different. 94% repair rate was really amazing at the time. So here comes double row repair in order to increase the repair integrity. Steve Burkett, Ian Lowe, and Steve Burkett reported the technical note of the arthroscopic double row repair to the Journal of Arthroscopy back in 2003. And the mechanical property of the double row and single row when compared with the transosseous with initial fixation strength and footprint coverage, repair size stability during motion, the double row is the most excellent when compared to other two procedures. So that actually this is the first single versus double row comparative study. Actually, I published in the journal Arthroscopy. I compared the my first series of the single row repair 39 versus a later 41 double row repair, and the functional outcomes repairing duty using MRI. And during the in order to report this outcome, I classified the MRI into 5 grades. This this is MRI classification. Type 1 and 2 is nicely healed. Type 3 is thinning. Type 4 and 5 repairs. So I think double row is a retrospective comparative studies, single versus double row. Double row is better in repair integrity, but functionally no difference according to authors, not just myself, the other authors as well. And also, this is a retrospective double row study with a substantial number of cases. We reported the JBJS 2007 and also the Paul Hausman, Joe DeVere. They reported the same period, the JBJS, and repair rate was 70%. And the Lauren Foss reported the 105 shoulders, and also his repair rate was 11%. And in the CT arthrography and MR arthrography. So that this double row repair rate after double row repair is very nice when compared with single row repair. Like these are all 11 to 70%, 17%. So this is my paper, repair integrity and the functional outcome after arthroscopic double row rotography. But this is published in 2007, and where this our repair integrity was small patient, small tear, patient with small tear, repair integrity is better. Type 1, 2, 3, medium size, type is expanded a little bit to type 4 and 5, but mostly the type 1, 2, 3. And a large tear, equally separated, equally divided, and also the number of patients who has type 5, 4, 5, 4, 5 increased. And the massive tear, the patient with type 4, 5 is almost half. So, and also this is a compared with functional outcome. This is interesting. Type 4, the functional outcome is very good, but only type 5 demonstrated deteriorated functional outcome when compared with other type of the repair integrity, like intact tear, or even with type 4. So I think the clinically problematic thing is the type 5. Type 4 is the problem. So I interpret this type 1 and 2, and including type 4 functionally very good. And the type 5 functionally deteriorated because this is a large tear. What about type 3? This is a little bit strange. This is type 3, external rotation is a little weak. So maybe I think some kind of tendon elongation or some kind of scarring, or maybe deep layer tear. So that's my interpretation of Sugaya classification. Okay, so single row versus double row literature review, long debate. So that I found the 5 level 1 studies. So when we look at these level 1 studies, this is very interesting. Small to large, small to medium size, smaller tear, and the number of patients is a little bit limited study. So there's no difference between single versus double row. However, with a double row is better in patient with larger tears, and also the number of patients a little bit higher. So I think the study, it is very interesting. The study for larger tears, and the Jim Pak published the paper, and he said the function is better in larger tears, and also double row is better, larger tears, and also Charlie Ma, he said the 3 inch more than 3 inch better is better in the forward flexion and external strengths. Also, this is double row is better. And also the Patrick Dana report that the double row is a function better for long term. So that's why if patients have bigger tear, so double row is preferable than the single row. So to summarize my single row double row talk, and double row is better in the larger tear, because double row is better in repair integrity in terms of functional outcomes, and also the strengths, including external rotation. Now, however, when we think about the cost and the insurance system, like the insurance system in Japan and India is totally different. So I think my conclusion is surgeon's preference. Okay, subscap has the largest muscle volumes, and also subscap is the only anterior component. This is very important for transverse forescapula. So the prevalence of subscap tear is reported by in arthroscopy. If we see this curve, and prevalence was reported that 27 to 37%, but including partial thickness tears, I think probably close to 50% or even more than 50%, based on my experience. So the symptoms of the subscap tear is very variable, including pain, weakness, catching, and impingement. Symptoms normally related to loss of transverse forescapula. And also they combine, normally the subscap tears combined with supra and infra tears. So that's why those patients has variety of symptoms. Subscap tendon test, bear test, reflex test, everybody knows this, reflex test. The comma sign, the comma is used randomly for the particular anterior tear group of fibers which connect the supra and subscap. So that's why during surgery we cannot re-establish comma, but my recommendation is don't cut comma, because this is a very important fiber go through the comma, which connected. This is a fiber which connects to the supra and subscap. So the footprint reconstruction type repair is preferred because in the most granular insertion area is about the strongest subscap. So that's why I prepared to perform the suture bridging, and actually I said this is our suture bridging sequence. I prefer to use a triple rolled suture anchors. We don't use no tying. We don't tie and bring the suture to the ladder without tying. And also finally, I tie the remaining suture in order to press down the calf to the footprint. This can, I believe this can avoid the stress concentration to the medial row. And my subscap repair, I prefer to perform the bishop position in the excellent visualization, no coracoid impingement. So coracoid impingement, the surgeons who prefer the lateral decubitus, then when they perform the subscap repair, they need to always, they tend to perform the coracoid impingement because normally arm is attracted to the anterior superior. So, but in the bishop, arm is gravity position, so that there are a lot of huge space between the coracoid and subscap. So that I normally perform the subscap repair in the subacromial and subdilated space. And footprint reconstruction type repair I prefer, and on the biceps management is very important. So the biceps, only 49% of biceps pathology was visualized by scope, so that's why we need to see the biceps pathology inside the group. That's very important. So that's why we do a cross-sectional, we measure the cross-sectional area of the biceps tendon inside the group. This is a hidden part of the biceps of the group using ultrasound. So my partner Nori published a paper, the hypertrophy of the extraarticular tendon of the long head of bicep correlated with the location of size of rotator cuff tear. It is very interesting. This is, we exclude subscap, subscap tear. If the patient has subscap tear, biceps hypertrophy frequently observed, it's okay. But it is very interesting. When compared to intact tear, intact rotator cuff tear, the process thickness tear, small tear, medium-sized tear, large posterior superior tear, the bicep size, if the posterior superior tear size increased, biceps tear size, cross-sectional area of the ultrasound in the biceps group increases significantly. So this is very interesting. bicep size increases with increase of posterior supercapsular size. So that means that's why if the patient had chronic rotator cuff tear, full thickness rotator cuff tear, I prefer to cut biceps because the bicep is not anymore the normal. This is the start degenerating. It's a totally different traumatic rotator cuff tear in a patient with in their 20s, early 30s or something like patient. And also the bicep pathology. This is also very interesting. Progression of the degenerative changes with biceps in tendon increase even after successful rotator cuff repair. Many years ago, we preserved the old biceps tendon because the bicep looks intact during surgery. So we preserved the biceps and repair the calf. And the intact and then the tear was successful. But sometimes the patient complains pain, anterior shoulder pain. So what's that? Because of biceps. So that's why we started the biceps tenotomy and tenodesis maybe more than 10 years ago, based on this study. Preserved biceps can be a possible cause of postural pain because chronic rotator cuff tear patient, more than 50s, 60s, biceps are already degenerated. So that's why the biceps is not normal anymore. So that's why the traumatic young patient, rotator cuff tear, and chronic rotator cuff tear in older patients already different. So the biceps, young patient, we preserve it. For older patient, chronic tear, we need to cut this. That's our concept. So bicep tenotomy tenodesis. When repairing particular rotator cuff tear, so we perform tenotomy and tenodesis. Remove pathological portion of the bicep groove, and also this is also very important to provide space for the subscap bridging. So that's why we normally perform the suprapec bicep tenodesis, arthroscopic, or sometimes we do mini open subpec tenodesis for young patient. But normally the rotator cuff patient with rotator cuff patient with chronic rotator cuff tear in the 50s, 60s, 70s, we do bicep tenodesis or tenotomy, and we remove the pathological portion, entire pathological portion of the bicep groove. So the subscap repair and the bicep tenodesis, we portal placement, I normally use the portals like this, anterior standard, anterior posterior, and anterior lateral, and the posterior lateral for the posterior superior rotator cuff repair. And also sometimes I use an visor portal. But for the subscap repair and the bicep tenodesis, I use these 4 portals. So normally the viewing portal is like this, or here, this portal or this portal. So that I use 4 portals for the subscap management, biceps and subscap management, like this. And of course, coracohumeral ligament is very important to release if you have retraction anterior superior tear. And this is the same video I presented in the previous talks, and it's a review, subscap breaching. So I preserve a comma and the press suture through the rotator interval, and the pressing suture through the bicep, subscap tendon like this. And I make a bridging, I insert the bridging anchors because I have already found bicep tenodesis. So there's nothing here, bicep groove. So that's why I insert the bridging anchor to the groove like this. And this is a view outside. And finally, I tie the remaining suture to press down the cuff to the footprint. This is a view from the outside. And also, this is a view. This is a view from the inside. Okay, so that we investigate the retrospective. We perform the retrospective outcome study. We have 101 subscap suture bridging repair, same technique, and 57 males, and including 57 males, 44 females, so 66 years on average, and 2.5 years, average follow-up of 2.5 years. And repair intensity was excellent. We had type 1, 2, 86%, type 3, 10%, type 4, 5, only 5%. And excellent functional recovery in shoulders with successful repair of those. And also, interestingly, strength was poorer in shoulders with higher grade pre-op fatty degeneration. So the muscle is very important. If the patient has good muscle, we can expect a very good strength recovery after successful subscap repair. But if the muscle is very bad, then we cannot expect the strength recovery. So let's look at the literature. Repair rate after subscap repair is a very limited number of articles, but in our repair rate was extremely good. It's only 5%, because I think maybe subscap bridging without time with a role. Just our procedure, our surgical procedure may contribute to the very low repair rate in our study. So how do we improve repairability? We have muscle assessment, is very important. This is a massive rotator cuff muscle, so we are very bad. Supra and also teres minor, supra, infra, and teres minor, no teres minor. And actually, this is a clear patient. So this is the ganglion patient, ganglion cyst patient. You know, the muscle assessment is very important. This patient has a suprascapular nerve injury, so that's why the T2 weighted images, the muscle looks white. But if we look at, if we see the T1, the no muscle atrophy. So that's why this is very important. So that we always assess not just the tendon itself, tear size, but also the muscle in this very, very medial side of the rotator cuff side. And assessing muscle is very important. So this is a case, large rotator cuff case, 63 years old male, he underwent the arthroscopic cuff repair and failed, and presented 6 months after primary surgery. And the previous doctor recommended the super arthroscopic patch procedure. So that's why he was referred to me. And it looks that very big tear, subscap looks bad, and the muscle also doesn't look good. But anyway, I put the scope in. You know, this is a revision 3 tendon tear case. This is a posterior view, big tear, relatively big tear, and also it was interesting. The previous doctor used only 2 anchors. He didn't even touch subscap. 2 anchors, double loaded 2 anchors. I think the previous surgery was very poor. So I mobilized the posterior superior calf, removing the soft tissue, and now I try to mobilize subscap. It's very retracted. Now I try to release the capsule between the glenoid and the subscap. So this is exactly similar to the banquet repair. And also the coracohumeral ligament, the MGH release performed. And I just exposed the base of the coracoid. Now mobility improved very much. So the 2 triple-rodded anchors are inserted to the vessel tuberosity like this. I placed all sutures to the subscap, preserving a comma and utilizing comma like this. And now I inserted the bridging anchor to the biceps groove. Biceps has already performed in this patient. And finally, I repaired the remaining suture, tying the remaining suture. So this is a view from the outside, vessel side, and this is a view from the inside. It looks very nice, and also the repair is very, very secure. And the posterior superior calf, this is a retracted, but not so retracted, so that's why I use a 3 triple-rodded suture anchors. And placing all sutures to the tendon like this. And finally, I insert the bridging anchor to the lateral side of the greater tuberosity. So in total, I used 4 in the front, 6 in the back. So repair is very nice. So this is before surgery. This is after surgery, 1 year after surgery. So this patient is doing very well, very well. So I think that this patient, this case, previous surgery was very poor. So the previous doctor even ignored the subscap. So that's why I think that the surgical skill matters very much in this case. So next case, this is the same shoulder, before surgery, after surgery like this. after surgery. So this patient has muscle, subscap muscles a little bit atrophic. Otherwise, he has very good muscles. So that's why this was repairable. Okay, so another patient, 57-year-old, large rotator cuff case. This is a traumatic rotator cuff tear. The patient got trauma 2 months ago. And this maybe, this is based on the subscap findings. I think maybe he may have chronic subscap tear and maybe acute suprainfra tear. So that's why maybe I think maybe acute on chronic tear. So normally we can repair subscap very nicely. So that's why I proceed to the primary repair, because only 3 months, 2 to 3 months after injury. So that's why the surgery, the 3 months of surgery. But you see, this is subscap. Look at this. Very poor subscap. Nothing there. Very poor tissue. Retracted. Very badly. You can see the conjoint tendon over there, right? This is very, very difficult. You see, suprainfra also retracted very much like this. I was surprised to see that. Is that same patient with this MRI? But he was the same patient. I was surprised, I see, with that. And I performed the aggressive mobilization, and also finally, I performed the footprint visualization, and I managed to repair that. But this repair is very high tension repair, so that it is not ideal at all. So that's why, okay, so this is after repair, and 3 months later, tear, retear happen, like this, retear. So that he underwent superior capsular contraction to SCR region. So that this is a very interesting case for me. So the acute large tears in young males, sometimes even if muscle looks okay, tendon retraction advances very rapidly like this patient. And emergency cuff repair is with a month or two strongly recommended if the patient has young male with big muscles and acute large tears. So I think this is a different line. So I think this is totally different from the most chronic rotator cuff tears. So that's why if you see large acute traumatic tears in young males, it's a kind of emergency situation. Okay, to summarize my talk, to avoid post-structural failure, rotation repair based on anatomy is recommended. And a footprint reconstruction type repair is strongly recommended for large post-superior tears and also for thickness subscap tear. Thank you for your attention.
Thank you, Dr. Sugaya. That was a wonderful talk, I think. Any questions to Dr. Sugaya on this talk? Yes,
there are two questions from Akshit. How to manage tear which is very close to the muscle tendon junction? And someone wants to see the functional outcome of these, the first very well repaired patient, if you have a video of that, and if you can share.
So muscle tendon junction. So muscle tendon junction tear normally happens in a traumatic tear in a young patient. So very severe case, I try to preserve the remaining tendon portion. So I insert the medial side of the footprint, suture anchor to the medial side of footprint, and repairing the muscle portion, and bring the suture bridging, perform the suture bridging procedure, and also placing sutures to the muscle and the remaining tendon, multiple sutures. So that's a very difficult situation. But in chronic tears and the tendinous, chronic tears with a very small amount of the tendinous stamp tear is very difficult, I think, very difficult. So that if you think that it is very difficult to perform the strong repair, maybe you should change your procedure. Maybe it's become superior capsular reconstruction or something. And what's that?
The other one is someone wants to see the function after revision. Any video you have, the functional video of the patient post-operative, how they are recovering and how well.
The revision case?
Yes.
The revision case?
Yes.
His function is very good. Very good. He's amazingly. He returned to playing golf in 6 months after surgery. He's been very good, doing very good. But 5-6 years later, he came back.
In fact, you know, Ashish, if you see his post-op MRI, that itself shows a very good muscle belly.
Yes.
The moment you say a fantastic supraspinatus muscle belly going, the function has to be fantastic. You know, that is what is the crux in revision. How you reassess the revision cases, you always see the amount of muscle which is gained after the repair of the supraspinatus tendon.
Yeah, there is one more question from the audience. Is when you release the coracohumeral ligament, is it from the joint side or the bursal side?
Coracohumeral ligament. Coracohumeral ligament release only performed at the bursal side. Bursal side. Just expose the base of the coracoid.
Okay.
You cannot release the coracohumeral ligament from joint.
Yes, Pratap. Unmute yourself. Unmute, Pratap.
Yes. When you
yes.
When you do a massive chronic rotator cuff tear, you always do anyway the biceps tenotomy. You utilize the bicep stems for repair.
What? Biceps tenotomy? What?
Will you use the bicep stem for your repair of the supraspinatus in chronic rotator cuff tear?
If the biceps remains, I cut the biceps. I cut biceps. I don't utilize that. Some Korean guys utilize the biceps tendon for repair, but I don't use that. I do superior capsular reconstruction or other things.
Okay.
But you know, superior capsular reconstruction is very invasive surgery. So that's why based on the patient's symptom, sometimes patient symptoms not so bad. And also the older patient, I do reverse.
Okay, thank you.
Hiro, there is 2 questions raised by Dr. Nicholas Anta. He has sent me on personal message. He's viewing us on YouTube. Nicholas Anta is a very senior arthroscopy surgeon from India.
I know him very well.
Yeah,
he's my old friend.
Yeah, he's a very active member, and he is one of the board member of Acacia. So he has asked you specifically how often you miss the subscapularis tear when you're treating the patient, and how often you can miss them clinically. The subscapularis tear, clinical.
Very often.
So any tricks to avoid that?
So, you know, preoperatively, the subscap tear is, we can see that subscap tear, the MRI, pre-op MRI is very important. So like muscle volume sometimes reduce a little bit, and also the subscap insertion site using the sagittal view of the MRI can tell the subscap, and also the symptom. But you know, that if the patient has dramatic posterior superior rotator cuff symptom, I sometimes miss subscap. But I never missed the neck thickness subscap tear, but I missed the partial thickness subscap tear many times. But partial thickness subscap tear sometimes normally doesn't cause any symptom. So
he has got one more question on this. When you see a full thickness subscapularis tear, there is usually the anterior superior escape of the humeral head. So do you post repair, do you check the Gothic arch, the arch which is created by the lateral border of scapula and the medial border of the humeral head? So do you compare anytime the Gothic arch creation as we compare in the trauma situation, the proximal humerus trauma situation, especially after subscap repair?
I cannot hear you well, so say it again, please.
Yeah, I'll explain you. The subscapularis tear usually has the anterior superior escape. The humeral head will go up
Okay.
And then once you repair it, it will come down with subscap repair. So do you check the lateral border of scapula along with the medial side of the humeral axis? Do you check that ratio, that how much it is coming in, is maintaining this arch, Gothic arch?
I think Gothic arch. Okay. I think the patient who has anterior escape because of the subscap tear and also the superior supraspinous tear, even after subscap repair, we cannot reduce that. It's very difficult. So sometimes in a patient who is massive rotator cuff tears and a symptom with anterior escape, but functionally not so bad. But sometimes in this situation, I perform partial repair. But in this situation, I do subscap repair and also the posterior repair. But I don't believe we can reduce the humeral head to the normal position anterior superior escape to humeral head to the normal position by the repairing subscap.
Yes, Vivek, you wanted to.
Yeah, I wanted to, I think, add to what Sugaya said. If you read his papers, most of the papers, what he said very rightly, that, you know, this debate between the single row versus double row has been ongoing. And, you know, people keep on saying that there is no difference. But what he brought out, the point is very valid. One is, most of the studies, if you see, are quite old. You will not find a good quality study after, let's say, 2013-14. Number one. Number two, most of them have got a very small number. They are a heterogeneous population. They have taken small, medium, large, massive. With that, even if your number is 50, 60, in your large group, you'll end up with something like 15, 20. And it is then very invalid to say that which did better and which did not. So I think what he brought out, and some studies have come up recently saying that the double row is certainly superior. We just now submitted our work for publication. It is a 5-year minimum follow-up study for the double row repair only for last years. We have not taken small and medium. And we also did not take massive because we realized that massive can, you know, change our statistics completely. So we realized that double row is definitely better. You know, yes, you know, I mean, there are many factors coming into the play, but if you see the structural integrity, there is no denial that the double row is certainly superior for the large tier. Having said that, I think more studies should come up across the globe, especially recent. If you see, most of the studies are before 2010. Not many studies have come up in last few years to actually substantiate this claim. And I'm a bit surprised because somebody who did publication in 2003 or 4 must have had a data of late 90s. Now, it's not probably very nice to compare a data of 90s in 2020. Maybe that one question remains valid. What's your take on this, Sugaya?
Yeah, actually, you know, the study, the comparing the single row, double row is very, very difficult because, you know, patient population is different and also the surgeon's technique, skill, everything is different. You know, even multi-center study is very difficult. So that's why I think, you know, like you said, large tear, I think double row is very, very important. Large tear for taking subscap tear. So that's why I think maybe many surgeons right now, they don't have any interest, which is better single row double row, because, you know, many surgeons study doing the suture bridging repair or other things. So that's why. So I don't care at all. But, you know, anyway, double rows footprint reconstruction type repair is preferable for the large tears, particular tears, and subscap tear.
Raghuveer, you wanted to ask?
Hiro, do you do the medialization of the footprints quite often?
Yes, I did. But recently, you know, the medialization, medialization and the cuff repair doesn't provide very good outcome. That's not anatomical anymore. So that's why I combine the superior capsular reconstruction. Maybe Mihata's, you know, hybrid superior capsular reconstruction. Do you know? Hybrid. Thin one, but just as a deep layer, superior capsular reconstruction and repairing this remaining cuff to the footprint. That's better.
I am not talking about those hero cases where you cannot repair and you have to do, let's say, like the last case which you showed, and you yourself said it was quite a tight repair. I am talking about when you cannot cover, let's say, 80% of footprint. You know that, okay, 50% coverage I've got. Can I medialize? Can I give a little bit larger area for it to heal? So do you believe in this philosophy? I mean, we have been doing it and seems to be happier situation, but yes, at the moment, I don't have a data from my center, but seems to be good. If you can bring it back, yeah, you can't bring it back 100% or 80%, but you are close to 60, 70%. And you say, okay, medialize by 4-5 millimeter and let's give a larger area to heal.
I think it depends on patient, the symptom, the patient's activity, and the age.
Okay.
So we need to combine many factors, then do that. You know. So if I feel 50% footprint medialization, and based on the tendon quality and other things, it's a little bit dangerous, and I need to perform the grafting. Yes.
Okay.
Sanjay.
Yes, Raghuveer.
Yeah, hero.
Yes.
So you said regarding biceps pathology, old patients, chronic tears, you do tenotomy.
Right.
But recent tears in acute patients, acute tears, whether you go by group pain or you go by ultrasound at our biceps pathology to do the tenodesis, whether you consider group clinical sign, group pain or ultrasound.
So I cannot hear you well. Sorry.
No, to do tenodesis, whether you consider groove pain sign,
group pain,
or you consider ultrasound of biceps.
Both. Actually, both. We do ultrasound examination, investigation routinely for a patient who undergo rotator cuff repair. So that's why we have the ultrasound information from every patient has ultrasound information, and also the pre-op symptom like bicycle group pain on vest, this kind of speed test, Jackson test, and many things. But even if they don't have any biceps-related symptom, I cut the biceps in the patient who has chronic rotator cuff tears.
Sanjay?
Yes.
Sanjay?
Samir, you want to ask?
Yeah,
I want to ask. Hero, in your double row repairs, if there is a medial sided row failure, when you are tying a knot, medial knot tying failure, in such cases, how you revise them?
Say it again, please.
Medial knot tying failure or the medial row failure in your series, how much percentage it is, and if this medial knot failure comes to you, how you treat them?
I don't tie medial row.
Okay, now you
I don't tie. I never tie medial row. I just bring the suture to the lateral without tying. Then actually I use a triple order suture anchors. So that I bring the 2 sutures to lateral, 2, and the 4 sutures in total to lateral without tying knot, and remaining 1 pair of suture I tie after bridging. So that's why medial row failure is very, very small, very small.
Roshan, shall we move ahead?
Yeah, we should move to the next lecture by Dr. Raghuveer. And after that, we'll come back to the panel discussion by Dr. Hiro Sugaya. Hiro? Now we'll have a lecture by Dr. Raghuveer on transosseous repair.
Okay. Raghuveer, can you share your screen, please?
Sugaya, do you remember?
Yeah, I know.
Yeah, 2013. Thanks, Roshan, for inviting again. I'll be speaking on these headings: arthroscopic transosseous cuff repair. Sutures have passed through the greater tuberosity a century ago. We are going through this cycle: mini open with anchors, with suture, double row, transosseous, and arthroscopic transosseous. This is the historical perspective. So I'm thankful to Sumant for teaching me the concepts of it. And we have got some Indian version of it, and some of our colleagues are also done on this cadaver lab. There is a sleeve, obturator, drill, tunneler, long drill, and suture passer. This is a granulated tunneler there. This is to deliver the Nitinol loop, and other is to hold on detected velocity. So this long drill will go through the Nitinol loop. As it engages, it won't come down. And we are loading the number 2 vicryl. So tunneler. And once we remove that passer, loop is left there, micro loop, which can be grabbed. So normally we make the medial tunnel where we normally place the medial row anchor, and intersecting tunnel is made to previous tunnel, and micro loop is pulled through the, so that we get past the sutures. We can pass 3 sutures. It's like a passing the triple loaded anchor in the greater tuberosity. And once the anchor is placed, we can go for suture configuration, whichever fashion you want. Simple, matters, bridges. The booklet has to tell that classical transosseous, it fails at bone because there are shorter tunnels near to the edge. Where we do modern arthroscopic transosseous, the medial tunnel is, we normally place at medial anchor. So transosseous equivalent we place here. That's why we get larger bone bridge. And these both tunnels are not in one plane. They are in 2 different planes, 2 different coronal planes. I will tell during the surgery. And fixation strength, some say it is almost same. And the article by Romeo, the transosseous equivalent outscores the transosseous. And this other study says that score is 78, transosseous is 468 only. But here he mentions that the type 2 failure is more in transosseous equivalent, whereas type 1 tendon tear is more in lateral edge, that is transosseous group. So this is made clinically relevant according to Sugaya also. So this is a small cuff tear. So now normally I use 2 orthocords and 1 non-absorbable fiber wire. Recently I started using suture tapes also. And if it's a partial lesions, we can convert it into full thickness and do this. And coming to, I'm going to the next large tear. Weak chair position in 4 tunnels, intraarticular view. So I do a biceps stenotomy. Now I'm in the dorsal side. I'm being from posterolateral portal, doing the soft tissue clearance. And I'm opening the bone footprint. Now we can see that medial tunnel is arm is placed in adduction. So I'm making the anterior tunnel. That is the number 2. Clamp is used to smoothen the tunnel. Now I'm showing the inside view. Initially I showed external view. Now I'm showing the inside view. So this will be a repetition. Similarly, posterior tunnel is made. That is number 1. So 2 medial tunnels are made. Now I'm passing the tunneler to the lateral portal, that is to the anterior tunnel. And I'm bringing the vicryl loop outside the anterolateral portal. Then this is the inside view. So vicryl loop is brought to the anterior portal, and these through sutures have been fed into the vicryl loop and pulled outside to the lateral portal. So this is a number 2 clamp. This is number 2, and remaining other 3 sutures are brought through the anterior portal. This I mark as 4. So 2 over 4 from anterior tunnel. So I'm showing the inside view. So same thing is done for posterior tunnel. So I don't go repeat the same steps. So vicryl loop brought out and 3 sutures has come out. So the posterior tunnel, that is number 1 clamp and number 3. So I mark it. So now all 4 sets have passed. 1, 2, 3, 4. 2, 4 belong to anterior tunnel and 1 and 3 belong to posterior tunnel. I pass the cannula. Now I release the number 1 clamp and bring these 3 sutures to the lateral portal. So bringing the 3 sutures to the lateral portal. Now I use antegrade or retrograde or clever hook to get the sutures. It is a delamination. I try to get the bites through both layers. But Sugaya has taught us, if they're delaminated, take the bites from 2 layers. So these 3 sutures are brought to the posterior portal and clamped it. Now I release the second clamp and bring these 3 sutures outside. Again, take the bite same fashion, violet, fiber wire, and blue. So these 3 sutures which are brought from anterior portal now they are combined with 4 clamp. 2 or 4 are combined here. Now I release the first clamp here and leaving the posteriormost suture, other 2 sutures are brought through the anterior portal. Yes, leaving the posterior suture, other 2 threads are brought to the anterior portal and is combined with number 3 clamp. Now I am trying to make a suturing now. Plan is to pick up 2 greens, that is 2 violets here, 2 greens coming here. You can see all other sutures are rolled together to the anterior portal. Last is holding to the anterior portal. So I pass a simple suture or sliding, a non-locking sliding suture. The suture which is coming from the cuff is made a post. You can see that knot is made, is on the bone here, the first knot. Now I'm trying to interlink the suture. I'm bringing the 2 red ones, actually 2 fiber whites, bring it posteriorly and making a knot. So I want to interlink the tunnels. So other end of red threads are pulled out. temporary clamp here. Now I can see the inside view. This is the only knot which is going on the cuff. Remaining all our knots are on the bone. So most of the knots are on the bone, only the here one knot is on the cuff. Now I'm trying to bring these two blue sutures coming across the interlinking knot. It's like a bridging suture. Now this knot is made, blue knot is made. Now I am tying this fiber wire knot, white one. Correct. Now I have started using the suture tapes instead of fiber wire. So interlinking knot is completely tied on the bone here. Now I'm trying to bring another green sutures, two blues coming across the interlinking knot. Knot is made again here on the bone. And this is the last one. Now you can see evenly, cuff is getting evenly compressed tightly to the footprint by this interlinking and bridging sutures. And this is the intraarticular view. And this is a reverse L-shaped tear. And I'm bringing this apex, or pulling this apex and holding it and suturing it here. And this is after the repair. This was a urologist. He had a massive tear, 3 tendon tear, presented with pseudoparalysis, supraspinatus, infraspinatus. He was going on the running jeep and his gun has recoiled. He has fallen from the jeep. And this is the cuff repair. I used 3 tunnels. So we have almost 9 threads middle tunnel. So total 18 threads. And this is the interlinking suture, first bridge. And the interlinking suture number 1. Second tunnel here and third tunnel. He is doing surgery after 4 months. So what are the concerns with this technique is bone tunnel placement, number of tunnels are in the surgeon hands, but bone quality it is not on, it's not our hands. So most often they say this technique fails by cut through, but it is not often because the Japanese study, the Kuroda in his study out of 384 cases, he had only 1 cut through, the 2 elderly female with lumbar vertebral compression. In Krishnan article also, he didn't come across with not a single cut through. But if I think that if we cut through, we can use this peak coupling. It can happen through any technique, the double row transosseous. We can go for convert into the mini open, or I can use a suture washer. And most often, some tears cannot be pulled all the way to cover the old footprint. So I avoid this transosseous technique. I either go with single row or transosseous equivalent. Wherever we use a lasso loop technique or mutilation of footprint versus augmentation, in this type of cuff tears, I don't do transosseous cuff repair. So, though in vitro studies, the transosseous equivalent has outscored the transosseous method, but in vivo results are slowly coming better. This study by Randelli, the initial post-op pain is less in transosseous equivalent. When Japanese surgeon Ivanovsky said by his contrast enhanced ultrasound, the segmental vascular flow is better in this transosseous equivalent. And even strength pattern, if you exclude the retears, if you compare both transosseous and strength is more in transosseous equivalent. And in Suman's paper, a type 3 tendon healing, he mentioned in this is by Sugaya classification. This is type 1 is suction thickness with homogeneous low intensity. Type 3 is insuction thickness without discontinuity. This is type 3. So in this article, he says he has to compare the transosseous with single row only and tears not larger than 4 centimeter. There is no significant difference in clinical outcomes or failure rate. But this type 3 Sugaya healing is more in single row repair than transosseous. You see here, type 3 healing is more in single row repair, whereas type 3 healing in transosseous is less in transosseous repair. So that's the reason the strength is more in transosseous method. So we have done this case in 2017, 30 cases we compared, and we followed in the Sugaya type of healing. This is a type 2 healing, and this is type 1 healing. To conclude, this is cheaper in compare, but if you want to do a mattress suture, it's slightly demanding, but most of surgeons are now exposed to this. So the transosseous method should not be a problem. Maybe in coming years, the literature might support in vivo literature, and revision surgery is much easier because there is only type 1 failure. There is no type 2 failure in this method. If something goes wrong, we can go for revision. So take home message is a true transosseous anatomic repair. It is reliable, reproducible, both mini-open arthroscopy is possible. It is equivalent to current methods, considering the repair integrity and biomechanical strength. And there is more biology and more easy reoperation in case of retear. Thanks for patiently.
Thanks,
Thank
Raghu.
you, Raghuveer.
Any questions? Anybody?
Yeah, we have one question for Ashish. Do you have any
Yes,
questions on YouTube?
Dr. Brajesh Kadri has asked Raghu sir is it difficult to make microfracture holes on GT with this technique? Is it very difficult?
No, there is here we are making the tunnels here, middle tunnel. That is giving the more biology. There is no requirement of microfracture. If we are using anchors, that's why there is a requirement of taking the microfracture. Right. That's why the vented concept, vented anchors have come, because anchors doesn't have biology. Initial generation have come with plain anchors. Now, the latest generation anchors are vented anchors. But in this technique, there's already you have middle tunnels. Almost 3.2 mm tunnel is there. That is enough for bone marrow.
Yeah, you must be talking about the crimson duvet concept.
Yeah. There is no requirement
of mix and match things, no. You
It's
cannot have everything in each technique.
Two different.
Yeah, apple orange. Raghuveer, excellent. I visited Sumant Christian in 2009, and this tunneler was in the evolution phase. And following year, it made available, and I imported it in next year, and then I started doing it. I did almost 85 plus cases. Even in one of the conferences in Samir Sheikh's course, I did a live demonstration of this arthroscopic transosseous. I was quite fond of it. And then slowly, I started having issues. There are two issues. One was that it was a financial issue, that Mediclaim patients would not get the reimbursement of this. So they were, not in favor of this technique, because then the expenditure was out of the pocket, where anchors were paid for. Now, secondly, I could not judge the quality of bone in every case. Even when I have started using it in younger patient, I had odd failures. I changed my technique from sliding knot to I went to the non-sliding knots. and that solves some of my problem. I started putting a normal, ordinary tailor's button to prevent the, cheese cutting of the sutures to the bone, but still I could not overcome. So I reserved them for the young, poor patients where the big tails where anchors could not be used because of the financial reason. And I had couple of patients coming back to me at 4 months following the surgery, and when I rescoped them, the cut-through method was not on table, but later on, probably because of high tension or whatever reason, it had, and poor bone quality, it had cut through the greater tuberosity. So these are the limitations of this thing. Otherwise, it is a fantastic technique. It is a biological technique, and in young and carefully selected patient, it works really well. The large retracted tears, probably, when there is a lot of tension, this is not a useful technique, but most of the cuff can be brought back to the footprint easily. This is a wonderful technique. And it is quick also. It is quick also. You can have 4 sutures to the tunnel if you want. You can create box sutures. You can alternatively place knots on the cuff and the greater tuberosity. Initially, when I started putting all the knots on the tuberosity, I had problem of the knots squeaking underneath the acromion and stuff. But they were all initial days. But I think this technique is quite evolved now. Thank you very much for bringing it to our attention.
Hero.
Yeah.
Hero. I
Yes.
think in Japan, do you use this transosseous technique, because Japan is also a cost conscious country as far as the implants are concerned. So do you use this technique, and what is your experience of this?
I don't personally perform this, and also we have cost problem, but we in our country anchors can be reimbursed. Anchors can be reimbursed. So many anchors we use. It doesn't matter. So that's why I can use a 6 anchors.
Roshan, this tunnel is an instrument. So in India, it can't be, whatever is implanted in the body is only reimbursed by this Mediclaim laws.
Okay.
That's a problem.
Also, you can, in Mediclaim, you can just get other rentals. There are fixed rentals, especially in the non-GIPSA. You can get rentals on this. Only in the GIPSA, Star gives and all the,
yes.
they give. That is sure.
But I think maybe the Butch's instrument costs a lot, right?
Yes.
It costs a lot. That's a problem. Actually, in our country, some guys are using this, but the problem is in using anchors cheaper, because anchor can be reimbursed. Using the Butch's instrument, that's even more expensive. So because that cannot be reimbursed. So that's the reason why we.
Hero,
Yes?
there is one question by Dr. Namdev from Miraj. He wants to know, do you do the arthroscopic as full thickness retracted subscapularis tear whenever you plan to operate? Do you do axillary nerve release, or how do you tackle the axillary nerve? Because it's very close proximity to retracted subscap.
I don't release the axillary nerve, but if I have interactive subscapula, I always try to see axillary nerve.
Okay.
To prevent injury. So that always I see when I place the sutures from the conjoint tendon side to the subscap, I always see the axillary nerve and check the position. So that's very important. But I don't particularly perform. I don't perform the particularly axillary nerve release.
So anybody has question before we go to
I had a question.
Yes.
Hello, Sri Trivedi. Hello.
Yeah, go ahead.
Yes, go ahead.
Yeah. This is regarding the cut through. Whenever we do the rotator cuff repair, after decorticating at the lateral to the articular area, so suddenly there will be a weak bone under if you do more vigorous decortication. So what do you think? I mean, your cut through is towards that side, or medial row side, or lateral row side? So most of the time, we won't touch the lateral side in this technique, I think. So
Jaya, in fact, cut through is from the lateral side, and if you see in this technique, it creates a little bit of triangle plus concentrated, which is only 2.5 centimeter max on the lateral side, and cut through starts from the lateral side actually, and never from the medial side in my.
Hero, we should go on to the case discussion. You have your cases.
Okay, sure. Yeah.
Please share your screen so that we can start. And I request Vivek Pandey. Can you hear us, Vivek? Vivek, Raghuveer, Jayaprasad, Samir. If you could hear me, Samir, all to contribute. Sandeep, you can also opine.
Sure, sir. Sure.
Can I go?
Yes. Go ahead.
Okay. So this is a little bit complicated case. So this is a case, 63 years old man. He fell on the right shoulder in September 6, 2018, and was referred to us from as 6 months after injury to complaining persistent right shoulder pain and weakness. Range of motion forward flexion 170 but painful, and the external rotation 50 degree, internal rotation L3. So he doesn't have stiffness but painful. And a positive cuff test. Positive cuff test means the strength is weak, and a positive whipper test, and also a positive bear hag and belly press test. So that we suspected a full thickness, supra, and 3 tendon test. The MRI shows the supraspinatus tear and also the infraspinatus tear. And the muscle looks not so bad. Subscap looks a little bit atrophic, but not so bad. And
what about his X-ray, Sugaya, Hero?
Yes.
X-ray.
Oh, sorry, I forgot to upload that.
Okay.
The X-ray was normal. X-ray is normal, I'm sure. Yes. No difference between the right and left. And the MRI, and this is a transverse view. He has the thickened biceps tendon, and also the inferior subscap looks intact, but the superior portion torn. So this is based on the imaging, the 3 tendon tears and the subscap a bit atrophic. Muscular is a bit atrophic, but retracted. Coracohumeral ligament release and the capsular release and the multi-layer supra-infra tear. So that I performed, this is the actual arthroscopic view. Can you see the video well?
Yes, we can see.
Okay.
Yeah.
So he has the posterior superior tear is not so big. He has medium size supra-infra tear.
Okay.
Yeah. And I performed the decompression first.
So do you do the subacromial decompression in each and every rotator cuff tear?
Almost. The patient has degenerative acromion. And now I open up the bicipital groove, and I placed in, I use in one suture anchor to perform tenodesis, bicep tenodesis. This is a supra pec. So now the supra bicipital groove is clear. So now I try to mobilize the subscap. This is a conjoint tendon and the C ligament. This is a view from the bursa, and now this is the coracohumeral ligament. You see, yeah. I try to cut the coracohumeral ligament. I just exposing the base of the coracoid. After cutting the coracohumeral ligament, the mobility improved very much like this. And also right now reducing the capsule between the subscap and medial side, the articular side of the subscap, like this, and the mobility improved even better. The almost reaches to the anatomical position. So now I decorticated just a little bit. I don't expose the entire soft cancellous bone. And inserting the 2 anchors. This is the first anchor, tuberosity. And another second anchor for the subscap repair. This is also triple rod, and this is double loaded. And the pressing suture, same. This is passing through the interval.
So you always place 2 anchors for subscap or 1 anchor repair for subscap?
Two anchors, 2 medial row anchors, yes.
Okay.
2 anchors. and pass through the subscap tendon. I grab the two sutures at the same time. So always looking at the, the conjoint tendon and the subscap. When I penetrate the disc on the suture grasper, so that I can see I can assess the distance between the subscap and the axial nerve. Now all suture has been placed like this. That's conjoint tendon, you see over there. Now I try to insert the bridging anchor to the bicycle groove.
Here in this case, you got complete reduction of subscap.
Yeah.
So total 3 plus 2 and 2. How many? 7 anchors or?
Four anchors for subscap.
4 acres.
4 anchors for subscap.
4 anchors.
Yes. So this is after repair, you see. So from the basal side, that's conjoint tendon over there. This is from the articular side. Very secure repair, right?
Yes.
Very secure.
Yeah, very secure and very good repair.
And also this is posterior superior calf. This is medium size. It is not so big there. So now I try to insert maybe 2 anchors. 2 anchors. 2 triple rolled anchors. So I grab 2 sutures at the same time.
So Hiru, you have now 6 anchors into the 2 medial for subscap,
4 for subscap,
and
4 for the posterior superior.
8 anchors. Wow.
Yeah, 8.
Oh, wow. Wow.
That's normal. That's normal for us.
I need to find the space for this many.
We have seen 12.
Number of anchor matters.
We have seen 12.
Okay.
Yes. Number of anchors is very important.
I was shocked for the first week when I saw 12 anchors.
Roshan, 12 anchors, 6 patients.
Yeah, 12 anchors is nice.
6 patients.
I can do 3.
I was shocked. Then it became normal.
But this
No,
can
yeah,
be
more number of sutures per the cuff area is important.
yeah. So in
This
a
is helix lateral, yeah.
Hero, at this stage, how do you adjust the tension till you see the fibers touching the lateral border of the tuberosity, or
Yes.
whatever you see?
anatomical position.
Anatomical.
Position. Yes.
This lateral row helix, especially what you're demonstrating, is it a very stable anchor? Because I find it very difficult anchor to rely on.
It's easy.
Easy?
Easy.
These are all bioabsorbable anchor, isn't it, Hiro?
Yes, bioabsorbable.
Ah, right.
By composite, actually.
By composite, yeah.
Yes.
And then you tie your medial row after
Yes.
fixing the lateral row.
Yes. Finally, I tie medial row like this.
These are the low tension anchor, medial row anchor, medial row tying. Low tension or high tension?
Low tension. Low tension.
You are tying in the medial side. No, is it a high tension or low tension tying?
Low tension. Low tension. Low.
Jaya, once you try lateral side, you cannot do anything more to the medial medial anchor tying to shift your cuff from that point.
Not that way. So what I mean, strangulating tying like very tough tying or just lax tying to compress that?
This is my typical rotator cuff repair. Thank you.
Fantastic.
Yeah, fantastic. So we have any discussion on this case?
One question for Mantav sir.
Yes.
Do you keep Sugaya sir from Mantav sir? Do you keep arm in internal rotation or any other rotation? Position of the arm during this repair?
During cuff repair, maybe 20-degree flexion, maybe 20 to 30-degree external rotation. That's it. I never change that. Only when I inserted the posterior bridging anchor to the posterior wall of the greater tuberosity, I internal rotate a little bit. Otherwise, always the same.
I guess Sugaya is still using the spider, right?
Yeah.
So he uses the spider.
You know that, Sissy.
How do you decide the tension in your subscap? Do you keep the arm in neutral while putting the lateral anchor or external rotation completely?
Subscap, neutral rotation.
Neutral rotation. Right. Do you use middle glenohumeral ligament to just check the, what is the tension into the, subscapularis or good position or bad position when there is a comma sign and middle glenohumeral ligament has gone behind the glenoid? Do you use it as a, kind of guidance from where to bring and what to bring to the lesser tuberosity?
If the little bit of retractor tear, I think the tension is tension depends on the release. So coracohumeral ligament release and also the middle glenohumeral release, middle and until inferior glenohumeral ligament release from the glenoid, and so in order to demobilize the subscap, that's very important. If you perform muscle release, so arm position or any other things, doesn't matter.
Raghuveer wanted to ask.
The final middle row tying, you are using the threads of both anchors or one thread from each anchor you tie it?
Yes.
Okay.
Yes. I bridge 2 sutures. Normally I use a triple roller anchors.
Yes.
So 2 sutures used for the bridging without tying.
Okay.
And always remaining 1 suture I use in middle row tie.
Yeah.
So when you tie, it is a mattress stitch, right? It is a mattress stitch?
Mattress, sometimes mattress, sometimes alternative half hitches.
Okay.
It's basically between 2 tunnels, 2 anchors.
Yes. So also the using the remaining sutures, I can manage the dog ear.
Okay.
Dog ear.
Yeah. Right.
That's very helpful.
It acts like a rib stop also.
Yeah, I can do that.
Any other question to Dr. Sugaya before we thank him and end the session? Vivek, you want to ask anything?
Again,
Vivek is speechless.
Dr. Antav's question.
There's nothing left.
And
we have been watching Sugaya now for decades.
Yeah, always impressive, isn't it?
Yeah. Can you hear me? Dr. Antav is asking.
This single row, double row issue. Do you think that issue has been put to rest among the arthroscopists, just like when open to arthroscopic conversion took place? People were comparing open with arthroscopic, and then when from single to double conversion took place, after a few years, the double row became a norm in the routine shoulder surgeons, and now there is no interest in comparing single with double row in any way, because they have believed that the double row is superior for the moderate, big, medium, and big size of tear. Do you think that is the reason less number of articles into the literature?
I will partly take your answer as yes. See, the thing is, there is still a lack of a very high quality literature. Me and Sugaya have said, see, most of the literature is old. Most of the literature is heterogeneous. So there is always a scope of establishing the fact beyond doubt. Charlie Brown uses a very right thing. He says equivalent does not mean equal. Okay.
Right.
Yeah, it may be equivalent, but the question is, fine, you are showing me a 2-year study, it is fine. But what happens in 10 years? If somebody proves beyond a doubt that transosseous equivalent for a large tear in it, versus the single row has been showing, has shown a superior structural, integrity for, let's say, 10 years, That's how you establish the things. Most of that is that 2 years, 3 years, heterogeneous population. So it remains, a debatable thing. But I think, I think in a accurate answer with the recent techniques, like Sugaya, the low tension repair. Most of the studies are 2005, 7, 8. We are, 15 years ahead. I think
I think with this, the hero.
Roshan, there is one question from Nicholas, sir.
Thank you.
Yes.
Last question.
Last question from Dr.
Does suprascapular tear take the same time to heal like the supraspinatus or infraspinatus? And any specific rehab for these patients when you have such a massive subscap tear?
You mean the 3 tendon tear
Yes.
compared to small tears? Yeah, actually, I tried to repair a very unskilled repair, right? So because of the aggressive mobilization, so the post-op protocol basically the same, But in a small tear, maybe a little bit earlier, a small time of the mobilization. But a big tear, maybe a little bit longer. Basically, the post-op immobilization is 4 weeks. Small tear can be 3 weeks. Large tear, big tear, poor quality tear, maybe 4 to 6 weeks. But that's it depends on patient. But basically the post-op protocol remains the same.
Okay, my own question, when do you do a MRI? Like after a year or still 9 months? What was the new protocol? When do you do it MRI?
MRI, post-op MRI, 1 year after surgery and 2 years after surgery.
2 years after surgery.
Yes. In a country, MRI is very cheap. And also the ankle can be reimbursed.
Yeah.
But Transosseous, the butcher's devices cost about maybe 5-6 ankles, same as. But that cannot be reimbursed. That's the reason why I performed the ankle repair.
Yeah. So I think we will end the session, but top secret we want to know from Dr. Hiro Sugaya today. He is in a live YouTube channel on Arthroscopy Academy. How does he handle so many threads of 6 anchors, 7 anchor, double loaded, triple loaded, 23 threads? And can somebody from India learn that trick of handling 6 anchors or 7 anchors?
And they are same color.
And they are same color.
Add to that, there is a song going on and he's singing also in the OT.
He's singing. And we have seen Sugaya dance. Sugaya has visited India many times. He has danced with all of us. So thank you very much, Dr. Sugaya, for wonderful time. These 2 hours has been excellent. And thank you very much.
Thank you.
We all from Indian community of arthroscopy surgeon will like to thank you from bottom of our heart. Yeah.
Thank you. Thank you for involving me.
Thank you. Bye.
Bye.
Just
Bye.
make it
Thank you, Sugaya.
Bye. Stay safe.